Essa sessão tem como moderadores o Dr. Cássio Peterka e eu. Antes de iniciar a sessão propriamente
So we'll begin now. Before beginning the session itself, I'd just like to stress an invitation to all of you. Submit all your best work or your review papers. We're going to make a special tribute to this meeting. The data is over here. There's a QR code that you can scan, and it will take you straight to the submitting website. As it is a special number, it is important that when you submit your paper, that you make it clear that it is for this special number. If any reader is interested in malaria in Brazil, they will have access to these files, which will be openly accessible to Brazilian researchers, thanks to the agreement between CAPES and Elsevier, and at zero charge. It's very interesting. This is for review papers as well as for regional papers. So that was my extra message. So that we do not waste any more time, I'd like to invite Professor Marcos Boulos to deliver the first presentation. He does not need to be introduced, but I feel obligated to say a few words. He is a doctor, a fellow and retired professor for infectious diseases in the medical school of USP. He was the director of such school, and he's played many roles both in academia, in the Brazilian Society of Tropical Illnesses, and in the Secretariat of Health. He's been extremely valuable in coordinating malaria and eliminating malaria in the ministry, and above all, in addition to all of his characteristics, I'd just like to highlight his skill to build bridges. He's been always very attentive to building bridges, to bringing people together, establishing contacts, collaborations. And I believe that this is essential for science work, for controlling diseases, and it is all too rare in our field. So I'd just like to begin this roundtable with Professor Marcos Boulos. The floor is yours. Thank you, Marcelo. Thank you to the event organizer for the invitation. It's great to be here. We've been here since the beginning. Claudio in the first, me in the second. I think that this malaria group started about 30 years ago. And we make a point out of forgetting, by the way. Otherwise, time goes by too quickly. Anyway, I was invited to talk about the history of malaria eradication in Brazil. I would say that this review is personal in nature. So I highlight the moments in which I was present in order to sort of make this presentation a bit more interesting. Oh, this happened and that happened. Then the cases were this and this happened. So for sure, other people would make different reviews, but this is my review. This is a graph that you have certainly seen, and it shows exactly what took place with malaria since the early 60s. We pretty much didn't have many cases before, about 50, 60 years ago. So what happened? It is estimated that we had about 6 to 8 million cases in 1950. And in 1960, we had none. Why did this happen? So let's begin by going back a little bit further. This is the electric plant of Itatinga. It is now in Bertioga. It started construction in 1905. The plant had to be discontinued due to the malaria outbreak in the location. I bring this up because the situation got critical to the point where they interrupted construction, and then Carlos Chagas came along. Oswaldo Cruz, at the time when he returned from the Institut Pasteur in France, where he trained in bacteriology, he went to Santos in 1899. And then he went to the Soroterapic Federal Institute, which later took his name, the Oswaldo Cruz Institute. And the recently trained Carlos Chagas in 1903 reaches this institute, and his defining work was the hematological studies of malaria. So in 1905, 2 years after his training, he went there, and this is a piece of curiosity. He was the first person who stated that the anopheline will, after passing, he lands on the walls, and that you could use insecticides on walls. It was a fundamental marker in malaria control at the time. He drained flooded areas and protected workers through many means. This episode became a world reference in malaria control. To display what a kid pretty much did, his importance. And 2 years later, in 1907, he also went to try to break the malaria outbreak in La Sanse, Minas Gerais railway. The next year, he saw triatomines on the wall. He desiccated them and found trypanosoma, and it was named after him, Trypanosoma cruzi. And then Berenice went there, found trypanosoma, and it became Chagas disease. So let's skip a few decades. Let's go to Anopheles gambiae. In 1930, Anopheles gambiae was introduced in the north, which was certainly the hungriest vector. Anopheles gambiae is explosive with malaria. From 37 to 40, we saw 20,000 deaths in the Brazilian Northeast, including the Northeast Ceará states. Bells did not toll at the time, and most of the population got sick at the same time due to the drastic reduction of the workforce, supply crisis. At the areas where it hit the hardest, people would just run from the most affected areas. A lot of families lost multiple members, and it led to a lot of losses. So it was really a political confusion at the time. They were simply not able to, find what to do. It's what Fred Soper was called. He works in the Rockefeller Foundation. He was intimate with malaria work. Then he went to PAHO. He was one of the members responsible for the eradication program. He employed insecticides, eliminating breeding sites. Intense surveillance and eradication took place in 1940. An important threshold because in 1941 we created the National Malaria Service in Brazil. Its objective was to control the transmitting mosquito, prevention campaigns, treating diseases, and mapping the endemic areas. Now see, because of the creation of this group, we can explain why we saw such a decrease from the millions in the 60s. This is a mitigation control during Ceará. So eradication in 1948, we created the World Health Organization, the world, I mean. Chloroquine had already been synthesized. We already used insecticide in the walls, so we had the weapons, the means to eradicate malaria. So vector control, diagnosis and treatment, epidemiological surveillance, structuring health services, and phased campaigns, attack phase, consolidation phase, and maintenance phase, international cooperation, and health education. Those were the pillars. I won't read all of this. No need. So what happened? We had 4 to 8 million estimated cases in Brazil. The World Health Organization launched the program in 1955. However, the eradication campaign is signed by Brazil only in 1965, when malaria was on the rise. So before Brazil took on eradication, malaria was lower than it was later. So what happened? A reduction to 50 to 100,000 cases in about 10 years. It's even hard to believe, but remember, at the time, malaria was fundamentally urban. So of course, if you work based on all the criteria, it was easier to eliminate. Now, how do we get there? The first structured actions began in the 50s rather. They were created the work group for eradication and control in response to the World Health Organization, and with the support of international mechanisms in 1958. We already had control with eradication experience of Anopheles gambiae through the National Malaria Service, the use of insecticides, drainage, and here we see an individual called Mario Pinotti, who was also responsible for a project for distributing chloroquine salt. He mixed chloroquine with kitchen salt and would distribute it to the Amazon community. Claudio's not here, but just to remember that Claudio was also in the meeting. The Brazilian Academy of Medicine, Mario Pinotti was a member of it, and Claudio headed it at one time. So chloroquine salt. People loved chloroquine salt. I remember Edmundo Juarez from the Public Health College, the coordinator of the malaria program at the time. He would say that this saved many lives. But what happened? A lot of humidity in the Amazon, the chloroquine would deposit, it would grow yellow and become bitter. The community would throw out the chloroquine and use just the salt. Of course, resistance would come up. It's said that the first publication on resistance was in 1961 in Colombia, but in 1959 we already had resistance in Rondônia on the border with Bolivia. I saw this on a report by the eradication program done by Susain, where they showed resistance in 1959, but they didn't allow it. I don't want to publish this. This is very academic. I'm not an academic. I don't want to publish this. He took it from my hand. Anyway, so where did we find malaria? Where were the transmission regions, rather? All of this, and you can see here that in the south and southeast. Sometime later, transmission began happening in Amazonic regions, so Pará, Maranhão, and Santa Catarina in the south. It's a special case that I will briefly mention. 70s is what I call the Pará decade. So in 1970, I saw the National Integration Program. Brazil needed to assume the Amazon. So I remember in São Paulo, Minister Delfim Neto went to the University of São Paulo and said that we needed to invest in the Marabá work, where we had the most advanced campi. because the Trans-Amazonic Road and its building led to many conflicts. And the colonization of the Amazon, the president would say that the north was extremely important for Brazil. And they would say, oh, if you go 5 miles to this side, the land is yours.
Quando a gente perguntou para o Delfim Neto, Delfim, e a malária quando você quer investir?
And when we asked him about malaria, oh, we want to invest in an economic program, and he said, oh, it's the Ministry of Health's problem. So we have many developmental projects at the time. It was in this location where we saw the guerrilla of Araguaia. So we would get to the campus and we would be accompanied by people we did not know because they thought that guerrilla warriors would come from the universities. Anyway, the Tocantins River, and I was really impressed. There was really rampant malaria there. I would discuss it with the doctors. The students would get there, a line of people with malaria. You have fever, okay, take chloroquine and go. Cases would not be discussed. And we would see that about 30% of the malaria cases would not be malaria, but they would all be treated. So let's talk about Serra Pelada. I didn't go to Serra Pelada. It was a security area, but we saw the miners there. Sebastião Salgado is a photographer who spent some time there. He called it a human anthouse. People just running every which way, fighting. There was no malaria there because the army didn't allow it, but there would be a lot of deaths because of infighting. I'll have to rush. If I keep talking like this, I won't finish. So the largest iron mine in the world here, people would come to work because there was iron and other minerals. And then the Tucuruí plant, a hydropower plant in the Tocantins River, it was led by Camargo Correia, and we went there to try to control malaria. There was no malaria in the plant. It was impossible. They were very close. They were divided in 6 categories. If you know about this kind of organization, then you know this. There was a category for the cafeteria, for the housing, and for the engineers, etc. We weren't able to treat there because they would only fund other places. So this is Marabá, the Araguaia River, Tocantins, the Tucuruí plant, the Carajá mountain range, and Carajá is a small city where the guerrilla warriors were come. So let's move to 70, 79. Rondônia came into place here, came into the fold, and I call this the Rondônia decade. Rondônia state in the 70s had about 111,000 inhabitants. In 1991, it grew tenfold. So how did this happen? This boom took place due to the building of roads, especially this road, 77 Vilhena, then 77 Paraná, 77 Aru. All these cities came up in 1977. A lot of migration. Machadinho do Oeste as well. I was there at the time, so I visited this region at the time. Agricultural colonization. We saw huge migration due to agricultural commercial projects and mining, the mining of the Madeira River. You see these tubes. Some of this was for gold aspiration. There was a lot of gold, they would cut it, and the diver would go down. Because there was some division, because the diver would keep 50% of the gold. When there was a lot of gold, they would, do away with the diver. Anyway. And then Cimetron, I'll briefly mention it. I went to the World Bank to evaluate the impact of the BR 364 road. One of the people I took there was Aloysio, the current dean. He was there at the time. But I was invited by the Secretariat of Health because they wanted to create a malaria hospital. It was a meeting with CNPq. I went there. I was at the funding meeting. And then, we would take the doctors and go around the cities along the road. It was around this time that Professor Camargo sought out a place to work. I suggested this because they were building a new hospital. And 1 year later, Marcelo Urbano Ferreira, who had just been trained, he arrived and was bitten, and he remained there to be treated for malaria.
I was going to a conference of malaria in Amsterdam, and I showed them the work Marcelo has done, and he remained studying malaria. You can see what happened from 80 to 88. It went from 79 to 250,000 cases of malaria. 50% of malaria in Brazil was in Rondônia. And we told the governor that we needed to do something. At that same time, there was malaria happening in Guarujá. We had 6 cases in malaria, and we saw a new one on the news every day. And in São Paulo, people were saying, we have 300,000 cases, but nobody says anything. This is the beautiful São Francisco do Sul, a city in Santa Catarina, surrounded by woods, and malaria wouldn't miss it. And there's a minister of health that said, we need to end malaria in Santa Catarina. So we did surveillance, we did radical treatment, but we did not eliminate malaria. We did a complete treatment of the patients and the reduction of the flowers. We removed the flowers where the mosquitoes of malaria used to mate and used to live. The flowers of bromelia. We had 630 cases in 1999 in the Amazon. That is how 1990 started in Brazil. And the minister was going to go through history as the minister that allowed malaria to get to 1 million cases in Brazil. So he then implemented a program of actions of malaria control with appropriate diagnosis, treatment, stratification of risk, focused vectorial control, education and mobilization. And the results were a significant reduction. In almost 2 years, there was a significant reduction of 50% of the cases, decrease in mortality, improvement of the diagnosis coverage, and the limitations were dependence of funding, continuous funding, difficulties in areas that are very remote, We strengthened continuous surveillance and adoption of communal therapies. This plan focused on management, performance, and sustainability of action, and in 2003 it was replaced by the National Malaria Control Program. This is the city of Santarém, in a region with a big number of cases of malaria, and Jacareacanga, where you had indigenous lands, and the famous mining in the Crapuri River, where the indigenous people worked and they still work. And now let's move quickly through what happened next in 2000, from 2003 to 2009, until you can see that the maps did not change a lot since then. And why do we have problems in elimination? Malaria and environmental change. Every 1% of increase in deforestation causes 6% of an increase in the cases of malaria in the subsequent months. This is a paper that was published in 2024. Another problem, when we were in 2003, malaria fundamentally happened in rural regions. The indigenous and gold mining sites reached 50%, and now more than 60% of the malaria cases come from mining, and especially illegal mining. An increase of 1% in the area of mining leads to 24% of an increase in the cases of the malaria in the Yanomami people. Cases of malaria in 2022 probably were under-notified in 83%. This is just an image to you. Illegal gold mining in the Yanomami territory and illegal landing strips for airplanes. They are all in the Yanomami territory, and they shouldn't exist. And with that, certainly you have a heightened area of illegal gold extraction in the indigenous region. All of these darker areas in the map are illegal and organized by the organized crime. The red ones, the red areas of the map, are organized by two different factions, Comando Vermelho and PCC. They are the ones who organize the illegal gold mining in these areas. That is why it is very difficult to eliminate the activities. This is how we knew the original peoples with their traditions, and then they were transformed into this that we are seeing here in the pictures, with the illegal extraction of gold, illegal mining, disease, malnourishment, death, malaria. Malaria today, we cannot call it an endemic. We have to call it a syndemic, because you have epidemics with mercury, violence, sexual exploitation, use of alcohol, rupture of traditional values and norms. The suicide rates is more than double the suicide rate of the rest of the population among the indigenous people. And just to finish, some contributions on how to eliminate malaria: political decision on financing, participation in health, environment, justice, and indigenous peoples, participation of all federal entities, all of the country's entities, follow up on the program, the malaria program, the constitution of a technical committee to follow the advisory on measures, surveillance, and keeping the dream, the shared dream, alive, and finally, lots of strength, lots of drive. I will end now with this picture of the Tapajós River, and I would like to thank Massa, because part of this presentation had Marcy's contribution, Alexander, Pablo, all of the people who not only provided me with these charts, but they keep alive our willingness to participate in the elimination of malaria. Thank you very much.
Bom dia mais uma vez. Obrigado, professor Marcos. Sempre muito bom ouvir você falando. E agora, para a gente ouvir falar pouquinho da iniciativa de
For us
eliminação.
to hear a little bit about the initiative of elimination of PAHO for the region of the Americas, I'm going to invite Dr. Sheila Rodovalho. She is a biologist, doctor in tropical medicine, and she's the national officer of PAHO Brazil. Sheila, please.
Obrigada, Cássio. Obrigada, Carol. Obrigada, Daniel, pelo convite, pela proposta.
Thank you, Cássio. Thank you, Danielle and Carol, for the invitation. We changed a little our presentation because the idea here is to present that PAHO does not only plan the elimination of malaria, but we have a whole agenda of elimination of diseases. So we need to think that when we want to eliminate diseases, we need to have the engagement of the policies and the entities. I remember when I joined the malaria program, if we don't involve the political part, the politicians, we don't have the process of elimination. How do we convince these administrators when we talk about money, when we discuss money? When we invest $1 to eliminate neglected diseases, we have a return of $25. So if we think about the amount of people they're treating to eliminate neglected diseases, in tuberculosis, every $1 invested returns $25 in investments. Healthy people being able to bring returns to the government. For vaccines as well, when we think about ending HIV, we have a return of 24 billion. The socioeconomic impacts as well, we have this return of $16 billion. When we imagine ending these diseases, when each person, government or from the academia,
retorno muito maior do que o gasto que ele está tendo. Não é? Mas as Américas, por que a gente está trazendo essa proposta de eliminação de outras doenças, principalmente na região das Américas? As Américas mostram, historicamente, que é possível eliminar
The
vários
Americas show historically that we can eliminate aggravations. We have here that America is a pioneer in the elimination of several diseases, among them measles and rubella, and also in other countries. We have elimination of vertical transmission, malaria, the elimination of the vertical transmission of HIV. So we show that we can be pioneers on that. And PAHO in 2019 has this proposal of the elimination of a list of 30 diseases. So what would be the lines of action? We need to strengthen the systems and the deliveries of the healthcare services. When we have the link with this local strategy of malaria, it shows that the surveillance systems have to be strengthened. We should also solve social and environmental issues. Without this evaluation that Marcos Bolos mentioned here, and he showed at the end of his presentation, if we don't understand the environmental context and the social context, we're not going to be able to eliminate the disease. And this is a heterogeneous issue. It's not the same thing talking about the Yanomami and the Munduruku, or speaking of the riverside communities and the illegal gold miners. These are completely different social determinants. We also have to work on the preparation and other lines of action. So we have to strengthen governance. We need to give continuity to people's lives, evaluating since the beginning women who are pregnant and children and elders. All stages of life are important when we think about each type of disease. And we also need to think about this foundation of human rights, gender equality, and populations in vulnerable situations. If we don't have these lines of action, and all of this connected, we can eliminate the problem occasionally, but it will return. FAO has a list by 2030 of 30 diseases and aggravations related to environmental issues. Malaria is contained in this list because it is not necessarily that all these diseases are going to be eliminated in all countries by 2030, because this is not going to be doable. But there are those countries that can select the number of diseases that they can eliminate by 2030. We need to have an integrated mandate. We need to try to understand what is possible to be done. So an example here is this initiative of the elimination of vertical transmission, where we can show that we can work with integrated diseases. We can do that, and we need to do that. So if we don't think about healthcare services and research that is integrated, we're not going to reach this goal. FAO's mandate for this initiative of elimination is to eliminate up to 30 transmissible diseases and other related diseases by 2030. We need to integrate the systems of healthcare services, the governance, work with frameworks, guidelines, roadmaps for each disease, and also try to integrate them, and also have a shift. We need to go from this control mindset to the elimination mindset, and that is what we have been disclosing here for the malaria program, but thinking about all of these other diseases too. So PAO has been working on this roadmap with the countries to do the approach of the program of elimination so that the governments can think together, and we are achieving it. The first step is to form interprogrammatic aspects. We have other sectors other than health that needs to be included in the elimination of this disease. We also have to assess diseases that could be related in their transmission. So why am I going to work only with malaria if I can in an action of assess other diseases? For example, if I go to an indigenous land and I'm going to study malaria, why don't I study other diseases? We cannot think only in boxes. We need to have this integration. So we need to identify capacities. We need to try to understand gaps. We need to try to formulate hypotheses that are critical for the work, and with the government, select and develop these initiatives. This is a map of how PAHO is already working for this development with the countries. We have an area of the elimination initiative that converges all of the other aggravations of transmissible diseases and other determining factors of health, both environmental and social determinants. There are some countries that already have their integration and elimination plans. We have Brazil, Colombia. We're working with other countries that are developing their plans and programs, and some workshops, because we need to have advocacy. PAHO does this advocacy so that the country as a whole can work on not a government policy, but a state policy. Brazil launched in 2024 the decree of the program Healthy Brazil, Brasil Saudável, and it starts our work in a list of transmittable diseases with the focus on social vulnerability. It was a great example because after Brazil, Colombia did the same, and the next year, and the following year, they also started working with their own list of diseases, but also they built the integrated elimination program. Panama also did the same. It has this proposal, this approach, and the message here is that not necessarily we will be able to add all of the diseases to the list, but we need to assess which ones are more viable at that time, which ones we are capable of integrating for starters. But you don't have to add all of them. We also have this monitoring in the initiative of elimination, and we assess how the countries are following the monitoring process. Here we have the website of the Elimination Initiative, where we have several dashboards, and we also have best buys for each aggravation, for each disease, and to explain the problem, how it should be conducted, what are the main goals and indicators that are necessary for us to be able to approach this subject. This is a dashboard where we do an evaluation of the progress among countries and also which are the indicators and goals that we need to achieve. We see a list of the aggravations that are here. You can access them. We can assess here according to the list of aggravations and diseases. You can see if the target was achieved, if it's nearly achieved, or if not yet achieved, or it's totally not applicable, or does not have any data.
In some countries, we have targets met, where some were not able to meet them due to aggravation, but it is very interesting because it is dynamic. So, for example, Chile, it was certified recently. So this changes as we meet more requirements. We also evaluate this whole based on the fundamental principles of those gears. We need to understand what are the systems that are integrated and deliver these services at primary care, who needs strengthening, who needs information. The strengthening of the integrated information systems is extremely important. Also, social and environmental determining factors and governance. So with all this, we're able to monitor, assess, and try to understand. We need better advocacy here. We need to work with this a little better in this location. And we continue to identify, course correct, of course, in partnership with the government.
A gente tem essa parte de ambiental e determinantes sociais.
So this is the social and environmental determining factors. Once again, it is not enough to just think about the disease side. We need to think about the people, the vulnerability stage where they find themselves. For vectorial transmission diseases, if we don't consider the impact of climate change, we will simply not be able to see the change, to see the effect of our actions. And so, we start looking towards the future. And it is, of course, possible. I talked about the best buys. This is it here again. We have this disease portfolio, so to say, and for each one you have this proposal. What are the impacts? What are the elimination targets? And what are the lines of action that we must follow? So small messages for these managers. And of course, based on these messages, we provide a wide array for the local government to do their work. They unfold. And Brazil in 2025 was able to eliminate the vertical transmission of HIV from mothers to children. So a country with over 200 million people was able to conduct that elimination. We also saw the elimination of filariasis. We are progressing in terms of trachoma. We also have many other countries with gradual proposals for the elimination of other aggravations. I'd just like to once again thank the organizers for the invitation. My main takeaway is that malaria is part of a package, but the proposal is, at the end of the day, integrated, and it is possible to work in this manner. Research and services. Thank you again.
Bom, muito obrigado, Sheila.
Thank you so much, Sheila. We stopped the order of the presentations because she talks about the perspective of elimination, so we can have an idea of what is the PAHO perspective. So to talk about the malaria elimination plan for the Americas, I'd like to invite Professor Roberto Montoya, a doctor trained in the Oswaldo Cruz Institute and regional advisor for malaria since 2016, right? Thank you. Thank you, Cássio. I'd like to thank Danielle, Carolina, and the organizing committee. Thank you so much for including me in the program. To me, it is extremely important to have this opportunity to share with you. They have this opportunity to share the 5-year plan by PAHO. It is an honor for me to share this session with Dr. Marcos Bolos, Sheila, and Marcia. So I'm very happy to be here. The Elimination Action Plan for PAHO for the next 5 years. So first of all, I'd like to talk about the achievements that we've seen in the past. Since 2018, we've seen some countries being certified as malaria-free since by the WHO. And these were extremely important achievements for public health. The first Amazonic country, Suriname, to eliminate malaria, the size of a Brazilian state. So you can imagine the challenge of eliminating malaria in any Brazilian state. And Suriname was able to eliminate malaria. This is a demonstration that it is possible to eliminate malaria in an Amazonic region. We really need to look towards the Suriname experience. But we have more countries getting there. In Central America, Costa Rica is extremely close. Very few autochthonous cases last year. In Mexico, I was there last month. They had 4 cases of malaria in the country. An enormous country who had a lot of malaria. Ecuador, after 100,000 cases, they have now less than 300. In the Dominican Republic, also very close. The French Guiana, also very few cases. PAHO believes that as a part of the plan of action for 2030, we will have 5 more countries who will eliminate malaria.
México teria que chegar hoje, este ano, a 0 casos. A Costa Rica também. Mas estão fazendo muito bem.
Mexico and Costa Rica are doing very well, and we could reach up to 5 years with no transmission,
2 anos, ou ano, 6 meses.
or at least 1 year, 6 months of continued with the continued absence of malaria transmission.
O grande desafio é a Sudamérica. O grande desafio Sudamérica e
But the challenge is South America and Haiti. I'll mention Haiti down the road.
aqui mostram como chegamos
These images show how we've reached that threshold of 500,000 cases. 2014, 15, we were stagnant. The issue is, after all, the Amazon region, the Peruvian mining issue. But still, we believe that we can reduce malaria in up to 50% by 2030. People tell me this is an aspirational goal, but I believe it is realistic rather. It could go much higher. It is extremely important for us to eliminate malaria in many municipalities. So in Colombia, Brazil, Peru, they could reach 2030 with many more municipalities with no malaria.
situações muito optimistas, na minha opinião. Vejam, neste ano 2026,
So this year in 2026, we have 0 cases of malaria falciparum in Costa Rica for the first time.
Centroamérica está mais perto do que nunca para eliminar malária por P. falciparum.
Latin America has never been closer to the elimination of falciparum.
Estamos chegando lá. Então,
We are getting there.
eliminação de P. falciparum é importantíssima, não só para
The elimination of F. falciparum is extremely important for the entire region, and it is possible. We see many positive results in the Amazon as well in terms of F. falciparum elimination. Our proposal is to reduce F. falciparum transmission by 70% and see the interruption of transmission in 4 countries in South America. We believe it is possible to interrupt F. falciparum transmission by 2030, and we have a technical plan for that. The elimination of P. falciparum is a priority in the Amazon region. We cannot wait. It will be much harder to do with resistance issues. So the plan for the next 5 years is extremely relevant for us because the next 5 years will dictate the future. It is the end of the Millennium Development Goals. The Pan American Health Association is focusing on these goals for 2030. We're seeing a lot of innovation coming up. We're seeing a lot of achievements that we must celebrate, and I believe that the next 5 years will be extremely significant to the control of malaria in the region. This is the preparation history. I just want to mention that it was very participative. There was open consultation with the countries, with experts, with advisory groups, and we announced the plan very recently. So the strategic objectives document must not be just a document. It must set out very clear targets. As a technical secretariat for the countries, this is pretty much a script for collaboration. It's a plan for us to follow for the next 5 years. The PAHO offices, all of the PAHO structure across the countries will follow the same plan. The idea is also for us to have a useful plan to inspire national plans as well. We also want to inspire multinational and sub-regional initiatives. We also want to promote the relationship between partners, so with researchers, with academia. We really want to promote partnerships. This is a very important part of the plan. And stimulate the countries to conduct these changes. And for sure, it would not be possible with just the Ministry of Health. Many actors in society need to be involved. And finally, the need for domestic funding, for malaria specifically. These are the strategic objectives. Now I'll talk about the structure of the plan. It's 3 strategic lines. First, the expansion of diagnosis and treatment as a specific line of work. All of the interventions are collective. So 16 interventions, 65 activities, and 160 tasks. So for the next 5 years, we have 160 tasks, and all of our work will be will have this as a guide. So it is impossible to do anything without proper governance and social mobilization. I've said this many times. The ministries will not be able to eliminate malaria by themselves. Communities must be involved in the elimination. So the main ideas for this theory of change that is proposed by this plan. First, to expand access to diagnosis and treatment. I'll go into detail a little later. Implement reactive interventions and chemoprevention. These are new tools that we're not currently utilizing as to their full potential. Reduce PVVAX relapses more effectively. Transform surveillance as a core intervention. Also extremely important and applicable. And optimize vector control. To meet the targets set out by the plan. And to consolidate subnational malaria-free territories. And I want to go into a bit more detail here, because malaria elimination will not take place overnight. Malaria elimination will take place with the joint action of many actors. So this concept of subnational elimination, especially in countries where we see a lot of administrative decentralization like Brazil, this is extremely relevant. To work with mayors, with governors. There are many municipalities that are perfectly capable of eliminating malaria. So the country must set out subnational targets. So how many municipalities will eliminate falciparum, malaria this year, for that year? The strategy must be subnational. So this concept is extremely important. Mexico is a great example. The process of elimination there was extremely interesting. It was essentially subnational. Of course, it was led by the Ministry of Health, and it certified municipalities and states as malaria-free. So these subnational targets are extremely effective. And Brazil is perfectly capable of setting out these targets. So these are the interventions. 1, 2, 3, 4, 5. Expansion, chemoprevention, reactive interventions. In order to eliminate, we must reduce the parasite reservoir. And I showed this yesterday, but I'll show it again. It is a main course of action here. The upper map is for the global strategy of control that we've been applying for 30 years. It was very tolerant. We're still tolerating this 1 hour, 2 hour, 3 hours. This was control. Elimination means putting diagnosis in places that are closer to people with rapid tests and providing treatment to all health units in the entire endemic area is essential. It is unacceptable to not have malaria treatment in health units within endemic areas. It is improving, and the community must have treatment in the communities. We must work towards having rapid tests and have these be simpler, better, safer, more effective. That's the role of innovation.
Diagnóstico y tratamento absolutamente en manos das populações afetadas.
Diagnostic and treatment must be at the hands of the affected population. It needs innovation, of course, but with the tools we have now, it is perfectly possible. The distribution logistics is one of the main challenges. There's a lot of room for innovation here. For example, the drones in this immense Amazon where transportation expenses are immense. So this first strategic line has a lot of elements. I won't be able to mention all of them. This is just to show you the structure and how integrated the plan is. And among these, there's everything that we've already mentioned here in this event. The need to improve access to technology, improve access to diagnosis. All of this is included in this strategic line.
The concept of DTIR, which is the concept of fast response, not interrupting the treatment, reactive detection of cases, response to cases, that demands a lot of intelligence and a lot of content that is definitely defined in these lines. We need local analysis. Malaria is something that demands a lot of local capacities to adapt the interventions. This is the example of an exercise that was done in Manaus. The exercise of trying to understand the transmission dynamics and where the diagnosis and the treatment should be allocated to. This is key, and this is all included in the concepts of the plan. Along those lines, there's also 32 tasks like the sentinel surveillance by the reports, as it was said here, integrating a network, a regional network that can contribute to surveillance to risks and this epidemiological surveillance too. Line 3 is collective interventions. We added territorial control with chemoprevention in the section of collective interventions that need a lot of planning and a lot of organization. We have orientations to the countries that want to implement chemo prevention with the steps and a roadmap. So we need to support the countries to implement these steps. And for the Ministry of Health to have a group of experts guiding concretely what situations could be beneficial. Countries have a lot of situations where they could benefit from interventions of chemoprevention in this moment, both for P. falciparum and PVVAX. And also include the concept of in collective interventions and PVVEX. I always bring this paper in my presentations on the elimination of Santa Catarina, in the state of Santa Catarina, with the use of serology to guide the intervention. This same method is being incorporated by other researchers. They're also using serology. And here in the region, we've already heard very good Brazilian experiences in the same sense. So I think that we should move towards this type of intervention that combines an individual intervention of expansion of diagnosis and treatment with collective interventions to reduce the reservoirs. That could be the final formula, high impact formula for PVVEX in the region. These concepts are all included in the plan. Also in vectoral control, we have in general the concept of optimization that was proposed in the plan, and we still have to build with each country. Optimization has to do with concrete things. The plan is beautiful, but we have to optimize these 4 points mostly. Prioritizing transmission acceptance. The ministry can spend millions in bed nets and lose most of this investment without acceptance. It is much more complex than just education and communication. Acceptance might become a prioritization criterion. This is all included in the concept of the plan. And finally, governance, financing, and partnerships are very important. The call to action for a political action for these kinds of decisions. We have to foster this in all the countries and reach elimination with all political willingness. This chapter here on support also has to do with the PAHO's capacity to join the countries in a sub-regional theme. This cannot be approached individually by the countries. It has to be a joint effort because the border malaria, the malaria in the borders is something that is a concern of all countries. All of these aspects that you already know need to be a priority in this plan. They are being covered by different parts of the plan. The plan explains this. For example, the elimination, the acceleration of elimination of P. falciparum has to be a main challenge, main priority. And it is completely possible to accelerate the elimination of P. falciparum in the Amazon. This part about governance has a lot to do with what was promoted by you and Carolina and Daniel with this meeting, promoting alliances. We saw the presentation of Gates Foundation yesterday, for example, how they're working on promoting a network and promoting partnerships. This is also a fundamental part of the plan, and I believe in it, completely. And finally, this transversal axis of social mobilization, I think it's paramount. And we have to engage all of the actors. I'm very positive. I have to be positive. I think we're going to get there. This has always been a motto that we have worked with. We can. Now we can. Now we must. And I think especially this country can. It demonstrated many, many times. So I would like to leave you with this message. Thank you.
Bom, Dr. Roberto Montoya, muito obrigado pela excelente apresentação.
Thank you very much, Dr. Roberto Montoya, for your presentation. Now we're going to pass the floor to Professor Marcia Castro. Hi, Marcia. Good morning. I'm going to do a brief introduction of Marcia. She's also one of these people that need no introduction to most of you, but it's always important to remember that Marcia is Brazilian. She has a degree in statistics at the State University of Rio. She did her master's in Belo Horizonte in demographics. She did her doctorate in Princeton, also in demographics, and currently she is a full professor at the Public Health School of Harvard in demographics as well. She's the head of the department, which is something that I deeply admire in Marcia, this capacity to combine the scientific activity with administrative work, which is not simple at all. And also, Marcia coordinates the program of the David Rockefeller Center for Latin American Studies. It's a great opportunity of interaction with the University of Harvard, and specifically for Fisher Peoples communities in Brazil. Marcia, of course, it is a great honor to have you here concluding our roundtable, and the floor is all yours. Thank you very much once again. Thank you, Marcelo. Good morning. I'm sorry that I couldn't be there in person with you, but I'm teaching this time of the year, so thank you very much to Marcelo, Danielle, and Ana Carolina for the invitation, and I'm going to share my screen so I can start my presentation. I would like to say that part of what I'm going to say is directly connected to Professor Bolos's and Dr. Montoya's speech. I will focus on the environmental and political aspects, and something that I hope that remains clear with my presentation is that these are not two separate things. The political part affects the environmental part directly, and even though I'm going to cover them separately, I'm going to show at the end that they are extremely related. Starting with deforestation, which, as Professor Bolos showed, was one of the main factors that led to the expansion of malaria in the Amazon with the opening of the border. And the model called development model, but actually it's a model of resource exploitation that ignores completely the needs of the region. With the deforestation, we have a environmental change that is very favorable to the sector, and that led to this border malaria concept that is very common in the Amazon in the 80s and 90s. It affects people in condition of vulnerability, and we have many of them there, like indigenous peoples and riverside communities, and there's an issue of mobility related to these environmental changes. You have a mobile reservoir for the parasite, which facilitates transmission. The important part here is if deforestation has the size it has, it is because of weak political regulation, and they may become even weaker depending on the political scenario. This is a very simple diagram. I don't want to say that this is a causal relationship, but it's very simple, and it shows that depending on the political leaders that we have, we may have an improvement in reduction of deforestation or a change in the decreasing trend that we have been witnessing. And we had that in the previous government with a scary increase of deforestation to levels that we hadn't seen for almost 2 decades, and that has repercussions in different aspects. This map here shows the area of the Amazon that was deforested. Everything that is in red was deforested until 2024. And what we can notice is, first, these white, very outlined areas are the indigenous areas that are protected. What we can see in this map here is that everything that is darker is a more recent deforestation out of this deforestation arc. And here we showed two things, malaria and deforestation. So the darker areas are where we have a lot of deforestation and a lot of malaria. So for us to understand the effects of deforestation and malaria, and Professor Bolas showed this number previously, we have to understand that there is a temporal component. It evolves, malaria evolves with deforestation. So in the areas where we have a lot of forest, where this environmental change is happening, and we can see exactly where it's happening, it's no longer in the deforestation belt. There are areas that are very preserved, and this is becoming a problem. Another issue is illegal mining, illegal gold mining, which also has the same political component that I mentioned before. It exploded during the last administration. Actually, over 60% of all of the areas mined in the indigenous lands in the Amazon happened from 2018 on. This shows the speed and the destructive power of this process, which is in this video. Almost 80% of the illegal mining, of the gold mining in the Amazon is illegal. It is not a regulated activity, and it happened during the previous administration completely uncontrolled. And again, this affects the populations in condition of vulnerability, which in this case were specifically the indigenous populations. And I would like to make a comment here because it's not only malaria that is affected by this environmental change, also other diseases because of the way that the mining is done and because of the activity that happens in the area of the miners. This chart shows that for the first time in 2019, we had over 20% of the malaria happening in indigenous areas. In 2003, it was only 2.8%. In 2020, we have 2 digits for the percentage of malaria in gold mining areas. And in 2023, it was the first year that if we considered the malaria in indigenous areas and gold mining areas, we had a rate of over 50%. If we look at only this black curve, this black line, the message is great. It shows that it's decreasing slowly, not enough for us to get to the elimination goal by 2030, but we have a change in the profile. And there's a bigger load in the areas of remote access, areas that you're having uncontrolled environmental changes, and in the populations that are in vulnerable conditions. This activity generates mobility. So here I'm showing the Yanomami area. These green dots are areas of mining opened in 2018. And I added a perimeter of 5 kilometers around them so it's easier to visualize. But we saw that malaria also increased in areas with no gold mining. And this is associated to the mobility of the gold miners in the area. This map shows a little bit of the cases of malaria that left the Yanomami territories and that searched for the health care and the routes that they use to seek health services outside the Yanomami area makes these reservoirs of parasites circulate and increase malaria in areas where we didn't even have gold mining. So we can see this exponential expansion with the increase in the number of cases. Professor Bolos gave us this number. Here we have a chart that shows the cases of malaria that could be avoided in the Yanomami territory since 2018 with the expansion of gold mining, and it's over 100,000 cases. It is not a small number, and if we add that to the proportion of total cases, we see the magnitude of the problem, which is very, very fast. Professor Bolos showed this map, and it shows that part of this illegal gold mining is controlled by the different criminal factions that unfortunately entered the Amazon. There is already a dispute for territory, and the orange areas showed an overlapping with the indigenous lands. Here you can see Cabeça do Cachorro with the Yanomami territory. So you have 2 factions fighting over control and fighting over these mining sites. In the Yanomami land, maybe you remember that there was a shooting that was carried out by organized crime. It starts with the lack of regulation, the political moment that lets the expansion happen uncontrolled, the effect of gold mining and malaria, but things are much more complicated when we look at who is controlling this area. The third environmental aspect is the extreme climate events. We need to talk about this. These are two photos of Manaus during the drought of 2023 and 2024, the worst ones ever recorded that happened earlier than expected in a magnitude that was never observed. When we think about this, there are two effects. The direct effects of this event, basically what they do is to change the geographical expansion of where malaria happens. You may have areas where there's no transmission and now there is, and the other way around. And you might have an intensification of malaria where it already happened, a reduction where it already happened, or nothing may happen to it, no change at all. The geographic area of the transmission and the expansion of the transmission are affected. They also affect access. Hundreds of communities were completely isolated without access to any kind of healthcare service or inputs during this period of drought, and that may affect the quality of the service provided. You might have interruption of services if the extreme event, for example, is a flood, and you can have a destruction of a health care facility. All of these indirect events are also very important for us to think about how this can affect the control program. And I want to bring you an example, which is an analysis where we measured the effect of the El Nino and La Nina phenomena, which are very specific in the transmission of malaria. And if we look at the big numbers in the Amazon as a whole, we observe less malaria. But one number less for the Amazon doesn't make sense because the Amazon is huge. So in the first line, you see the change of the transmission of malaria during La Nina for every quarter of the year. Everything that is green, you have less, and red, you have more cases, and in the bottom, you have El Nino. So despite having fewer cases in the total number, there are areas that are going to intensify transmission. So this detailed information is extremely important for the local decision making, and that has to do with what Roberto Montoya mentioned in his presentation and about the elimination strategy.
Again, in the context of drought, this map is from September 2024. We saw pretty much every single municipality in the Amazon presenting some degree of drought. And in darker, these are isolated areas where the population did not have access to anything. I mention this because, unfortunately, we do not yet have protocols for what to do during drought, during floods. We don't yet have a way to try to anticipate these effects and try to mitigate them. The 2024 drought made the gaps very clear. We were still very reactive, and therefore we weren't able to mitigate the issue. So moving towards the political side, there are many things that I wanted to mention here, which I believe are extremely important for us to think about. First, in terms of political challenge, political instability can take place anywhere. It can happen in Brazil, it can happen outside of Brazil, and even the ones that take place outside of Brazil can have many repercussions in Brazil. Venezuela is a recent case that made us reflect on that. The surrounding countries in America saw a populational exodus, a clear effect of the political instability there. In southern Venezuela, in an area that's very rich in terms of mining, we also saw an expansion of mining activities, which has a lot to do with what I mentioned earlier in terms of the environmental distribution. And in terms of political stability, borders are an issue. Things are not limited to the context where they happen. They have trans-border consequences. And this has an effect on control programs. There could be funding reductions, a lack of equipment, a lack of medication, or even personnel. So again, if you don't have a preparation for a crisis, this could mean a reversion of all past achievements, as we've seen in Venezuela. There's also the element of political leadership and long-term thinking. Unfortunately, this is a challenge for politicians. They usually only think about their own administration. And we do need to think about the long term here. In order for you to have perennial actions, resilience, sustainability, especially when you are faced with crisis, which can be political but also climate related, if you don't already have a plan that takes all these things into account, then you will always putting out fires. And it's this idea, being resilient. In the Amazon context, this involves many elements, including the already existing challenges, for example, in terms of access. It is crucial for this late elimination stage. We really need action focused on that. Crises really tend to stretch these challenges. So thinking about planning, Brazil is better placed than other countries here. We have many alert systems, and soon, hopefully by the end of the year, we'll already have a system for weekly mining alerts. So you'll get access to the information that allow for local decision making and a very quick manner to do it. We're able to respond quickly before transmission expansion takes place. Of course, in order for this to happen, we must have political commitment. As it was mentioned before, Dr. Boulos mentioned that you need boldness, you need political commitment, but in order for things to happen, in order for actions to not finish when transmission starts declining, we need that boldness. We've seen this happen in the past. There are many priorities in a political office, and they all compete for the same health-related resources. When malaria declines, you can see some relaxation of the actions. So it is extremely important for us to sustain actions even though malaria is on a downturn. This is also a part of that political commitment. I must also mention international collaboration. This is one example. The lines are drug trafficking routes. We see that these cross many borders. Brazil cannot solve this by itself, nor can the Ministry of Health solve it. It must be an effort by many countries. It must involve many sectors of the government of these countries. There are some dots that I'm sure if you can see. Each dot is a landing strip, and we can see that these landing strips are within indigenous areas, Yanomami here, and the routes go through these areas. So we're not just talking about malaria. We're talking about culture. It involves the sustenance of populations located in these areas. People who have been here much earlier than we might be aware of. And this makes it clear that environmental challenges are also political. We were able to reduce deforestation. We don't know if it will be sustainable. It will depend on the next few months. This is an election year. Hopefully, we'll not go back to a stage in which we will see a reversal of malaria achievements and also deforestation achievements. Maybe the hardest stage is this final stage. As Montoya said, we can and we must, but there will be a time in this closing stage that things will simply not move without political commitment. It will demand sectorial action, political commitment, and the acknowledgement of the fact that it must be sustainable, even if we're closing in on 0 and even after 0. Thank you so much for your attention.
Márcia, muito obrigado.
Thank you so much, Marcia. Very enlightening. We will now call back the speakers, Dr. Cassio, Dr. Montoya, Dr. Sheila. Marcia will just remain. Please take your seats. I have good news and bad news. Oh, Marcos Boulos, yes, Dr. Marcos Boulos. I just assumed he'd be here.
Bom, a boa notícia é que nós teremos espaço, acho que para 2 perguntas muito breves.
I believe we will only have time for 2 questions. Please be brief. And we don't want to go into the time of the next session. They will also be available during the coffee break. We're excited to get your questions. Don't be shy.
Fazer a primeira pergunta. Márcia, você vê as pessoas que estão fazendo as
Marcia, you can see the people here? Yes. It was a great panel. Thank you so much. It's a question and a comment because we know that at the federal level and at the state level as well, they are interested in eliminating malaria, but what is your perspective on the local governance that is extremely important for malaria elimination? So I think this question is for Marcia, but if anyone wants to comment, please. Thank you for the question. So the local level is a bit of what the program is doing. Alexa's team and Pablo's team, they are dedicated to that field work. There's a lot of awareness raising. They work in the sense of showcasing how the data can be used. Stratification is another effort. So depending on the transmission level of each area, and there is this local level at the program, there are actions that must be conducted, raising awareness about the rapid test. So the strategy of reinforcing local action will not be done in an office. It will demand the conduction of the actions laid out by the plan and go into these areas, showcasing the importance of stratification in these various activities, and we already see the results. There was a reduction in Acre. We see a reduction in other areas where the intensifying work is taking place. It is hard work. It is not easy, but it can be done. Thank you, Marcia. I have an example. In Cruzeiro do Sul, we had Pablo representing the ministry, and I was there. And the presence of the ministry with the people from the state and the city hall was already a huge achievement. It was extremely important for us to have that support. Just having them there. So the municipality can't do it by itself. There must be a correlation of powers. Municipality, state, and federation, stimulated by the federation. They are the ones that provide the resources for you to conduct diagnosis and treatment. So decision-making must be centralized initially, and it must reach the floor. But you can't reach the floor and not have the means to address the situation. We saw the waters that needed to be drained, and the local health department cannot address it. It must have that strong political decision and having the funding get there.
Só complementando,
just to complement,
essa parte de estar na ponta do Ministério mostrar e o Estado.
That grassroots work, that base work, and showing that the states and federation or in partnership with the municipalities is a very important message. We've seen that when you reduce cases, often you lose funding. And being present with that message of strengthening surveillance is extremely important. The local malaria programs, they are not strong by themselves to justify the resources. They will have to move around technicians, doctors to many places. And when you have that sort of local evaluation and the data assessment at the 3 levels, and when one of them suggests, come here, and having that visibility is very important. Because if the funding goes away, it will return, and we've seen that in the past. I'm just connected to an idea that I want to share. This theory of elimination, this theory of change must be demonstrated. I believe that Brazil and all the Amazon countries, they need a demonstration that it is possible to eliminate malaria. Suriname, for me, is that example. But I believe that Brazil also needs to demonstrate itself to itself. The technical side is not 100% solved. We have open questions, technical questions. So this needs to be fully addressed. After it is addressed, then it's just about replicating it. It's something we were talking about yesterday. The decision of the country to select demonstrative areas with that multi-level governance that you really need in the case of Brazil, federation, state, and municipality, academia, a series of actors, and organizing perfect interventions. To have these be the demonstration that it is possible. That's what I mean by perfect. To showcase that in this public health lab, so to say. It doesn't need to be huge. You can have a river or a riverine community. Just start replicating it. Just wanted to make this call. It's pragmatic, it's concrete, and absolutely possible in Brazil. Brazil has all the capabilities to have local demonstrations. And here we see also governance. Thank you, Dr. Cássio, will wrap us up. Thank you, Marcelo. I'd just like to thank everyone for attending. Thank you to our speakers. Malaria has always been very integrated in the health ministry service in terms of providing evidence. We've seen a bit of the PAHO plan for eliminating diseases, the malaria issue, and the malaria history brought by Dr. Marcos Boulos. How far we've come and the road ahead. Professor Marcia talked about the environmental issues, and what I see that permeates all of these perspectives, which is also related to the service, as well as to research, is political will, political mobilization, in tandem with social mobilization. This will be very much required, especially for the sustainability of elimination. I always talk to Sheila, Roberto about this. Suriname is a huge achievement. They are certified malaria-free, but if we, their neighboring country, don't move forward as well, it will be a very hard situation for us to not maintain that certification. So the work needs to be integrated. Micro-certification, micro-planning, yes, for sure. But we also have a health responsibility to solve this issue, not just for us, but for our neighbors as well. Once again, thank you, everybody. We will now have a coffee break, which can be for sure utilized to ask your questions to the speakers. Thank you.